All right, everybody. So one thing we talk about a lot here on the channel is COVID-19, its impact on all of our lives, its impact on the economy, and so many other things. Now, as you know, what I talk to you in my channel, I am not an expert in these things. I can just tell you what I read in the newspaper and trust that it's correct. But today I actually have an expert here with me who's going to talk about COVID-19, its effect on our lives, and how we can be safe going into the holiday season. I'm going to talk to Dr. Pascal S.C. Juwong, MD, also known as Dr. PJ, on social media. He grew up in Queens, there in New York City, attended Stuyvesant High School in New York City, graduated from Stanford University with a Bachelor's of Science in Biology and a Bachelor's of Arts in Economics. He received his medical degree from UC San Diego on a Regents Scholarship. He did his residency in emergency medicine at Harvard Medical School, where he was appointed the first chief resident of Harvard Emergency Medicine and a clinical fellow in medicine at Harvard Medical School. He has been invited to lecture at numerous meetings, written multiple emergency medicine textbook chapters and academic research articles in premier emergency medicine journals, and most recently, he did research on N95 mask cleaning and reuse in the Journal of Emergency Medicine, an article he co-authored with the inventor of the N95 mask. Dr. Juwong is also an entrepreneur, and because of prior experience on medical school and residency admissions committees, he founded Med School Interview Insider, advising physician assistant and medical school applicants, and he is the official PA Med School admissions consultant for Scribe America. Dr. Juwong has been selected by the Orange County Medical Association as a 2021 Orange County Physician of Excellence. He is currently a frontline healthcare worker practicing emergency medicine here in Southern California. And because of the pandemic, Dr. PJ recently started posting COVID-19 related information on Instagram and is currently starting a YouTube channel to educate the public about COVID-19, as well as to discuss his research interests in longevity, medicine, wellness, and emergency medicine topics. Now, I must remind you, just like I share financial information on this channel, and I let you know that it is just financial information, just my own opinions, not to be taken as financial advice. It's a similar thing here with Dr. Juwong. He's going to share medical information to you or with you today. Nothing should be taken as medical advice, and that anything he shares is his own personal opinions, and he is not speaking on behalf of his employer. Dr. PJ, welcome.
Oh, thank you for those kind words. I was pretty comprehensive.
Yeah, no, that's great. That's awesome. So let's get into it here. First, let's just set the groundwork here. Let's talk about some basic facts about COVID-19. So I've said the word coronavirus more times than I can count, probably in the last 8 months or so. So first question is, what is a coronavirus in general, and specifically, what is COVID-19?
Well, there are hundreds of viruses, and there are many types of coronaviruses. And when you look at that, I think what people don't realize is there's actually 7 human coronaviruses.
Wow.
4 of them are actually benign. They cause a common cold, and they've been around for a while. That's important later on when we talk about how it affects people and antibodies and all that stuff. But the 3 that are dangerous are SARS-CoV-1, which came out in the early 2000s, was a big deal. A lot of high percentage of people died from that. The second coronavirus was the MERS from the Middle East, and that was late 2000s. And that caused a lot of morbidity and mortality. And now we have SARS-CoV-2, which has been renamed as first the novel coronavirus, meaning newer. And now it's COVID-19. And coronavirus is the virus, COVID-19 is the disease. So that's a differentiation when you talk about this thing. It's kind of used interchangeably, but the coronavirus is named because viruses basically, think of it like a basketball with little spikes on it. So that's a picture that you might wind up showing that has basically those little red spikes, and people talk about spike protein. That basketball, think of the outside of that as a membrane. Inside is all the machinery for the virus, and that virus invades your body. That spike protein attaches to your cells, penetrates inside, and reproduces, kind of explodes a cell, comes out in thousands of copies, reproduces, and goes on to infect more cells, and so on and so on.
Okay.
So that's what a coronavirus is.
Now let's talk about the mortality rate for COVID-19. What is the mortality rate? I'm asking this as someone in my early 30s, generally healthy. Should I be concerned? What is the mortality rate, and how does it vary based on age, comorbidities, things like that?
Yes. So we kind of should segment mortality into age groups. That's the best way to look at it. And in general, the younger you are, the lower the mortality. Now, most people who are getting infected are younger, less than 40. And frankly, I think that's because those people have a kind of invulnerability sense that they feel, hey, this won't really kill me because I hear the percentage of death in my age group is much less than 1%, which is true. But when you look at the 80s and above, it's greater than 40%. And these are real numbers from the California Department of Health website on California statistics, which usually can generalize through the country. And when you look in the 50s through 70s age group, it's anywhere between 8 to 11% mortality. When you look at that kind of 30-ish, I think 35 to 50 age group, I believe it's somewhere in the 5% range. We're going to show a table on that in those range groups. And then under 30, it's really like kind of, you can think of it as less than 1% and much less than 1% when you're in your 20s and teens. So if you look at that and just do the numbers, just because there's a huge number of people under 40 compared to over 65 who are getting infected, then that drives down the average. But you got to remember that your dad or your grandparent, they have a between 10 and over 80 years old, 40% mortality rate, which is a big deal. And that doesn't include the long haulers who have long-term symptoms. Those guys aren't counted in the death rate. You got to remember there are a lot of people who have problems after this.
Now, you mentioned something that kind of made me think of something. Why is it that with COVID-19, the older you are, the more affected you are? It's my understanding, just as a layman, that with some other viruses, let's say influenza, right? It's kind of like, okay, the very young and the very old are, it's very susceptible to it, to having sometimes fatal consequences. But with COVID-19, it seems to just be the very old. What's the difference here? What's going on here? Why is that different with COVID-19 as compared to, say, the flu?
Well, first the flu. The high-risk groups are the babies, the older people, and the pregnant women. Those are high-risk groups. So we can't forget about the women. So
Okay.
the other thing is, the answer to the COVID question is, we have some thoughts on it, but right now we don't know for sure. And that's because it's only been around 7 or 8 months. So we haven't had time for long-term studies, etc. But some thoughts on this is, in general, when you're older, I mean, everyone, when they get older, your bodies they just aren't as good. You're not as resilient. You can't, your immune system is a little bit lower when you're older. Your arteries are not as good. Your body is kind of, the wear and tear on it just doesn't allow you to fight as much, we think. So, and then the older you get, the more medical problems you have. So there's probably some combination of all those factors that makes it so that the older people are affected in general, much more than the younger people. But we won't really know the definite answer for probably a few years.
Okay, got it. So lots of people say that COVID-19, it's just a bad flu, right? What do you say to people who say that?
Well, the thing is, for a lot of people, it will seem like that, but for too many people, it's deadly. And I posted something on my Instagram the other day that has to do with the death rates and all that. And like, overall, it's less than 1% for everyone. But there's those subgroups we talked about. And the thing is, for those people, they die and in much greater numbers than the flu. And on top of that, they get much more sick, insofar as that everything is affected. The pathology of COVID-19, it's really an attack on your blood vessels, on your immune system. It's what we call a microvascular disease, and it affects all your blood vessels with getting an inflammatory response. And so really every organ can get infected. So that means your lungs, your intestines, your kidneys, your heart, your brain, everything can get infected. And flu does not do that. And there's
Okay.
so many complications. And you've heard of blood clots. You heard of that actor, Nick Cordero, I think his name is. He first lost his leg, then he had kidney failure. Then finally, after I think several months, he died of it, just they couldn't save him because it affected everybody. And this was I think, 40-year-old, really healthy guy.
Mm.
So flu doesn't do that at all.
Okay, so the COVID-19, it's much more pervasive in the whole body, is what you're saying, as opposed to the flu, which might just affect your certain aspects of the body.
Correct. And also it just, in the bad cases, gets this immune response that really takes over and knocks out a lot of your body systems.
Okay, thanks. That's very helpful. Now let's talk a bit about COVID-19 in the United States. So I started hearing about COVID-19, probably late January, early February. And then it hit, and cases picked up throughout March, kind of peaked there in early April. That's when, there were lots of lockdowns and things like that. Cases remained steady for a while, and they kind of peaked again up in early July. And then there was kind of this steady decline, a gradual decline, all the way up until, let's say, early September. But since then, cases have just skyrocketed again, higher than those previous peaks, at least in daily case numbers that we saw in July. So two parts of this question. First, why did cases see that somewhat gradual decline from early July to early September? And then why from early September until now, September, October, November, have cases just gone through the roof?
Well, that's a long answer, but to make it short, it's because of, number one, the behavior of the virus, but number two, more importantly, it's the behavior of people. That's really the answer. And the big picture is this: COVID is around. It's not seasonal like we originally thought it might be, and go away in the summer and come back in the winter like the flu does. Okay. Think of it like, you ever see those zombie movies?
Yes.
Zombie has to bite you, right? And then it bites you, and all of a sudden you turn into a zombie. So you don't let those zombies close to you. COVID, think of it the same way. You don't let people close to you to exhale the viral particles so that you inhale them, or you're exposed to them, or get in your mucous membranes, or you touch them, etc., and touch your face or your eyes. And if you do that, you can't get it. It's so simple, right? But what happened was, everyone saw those pictures from New York City, right? Morgue trucks, the hospitals lined with, gurneys, and people dying in the hallways, people, in China, they're just laying on the street dead. I think what happened was that really put a lot of fright in people, so they really complied with the lockdowns in March. And what happened was, then the numbers went down. Typically, the numbers will lag the infections and human behavior. So if humans do certain things that don't allow that virus to spread, then several weeks later, it'll die out, because the natural course of the virus in your body is, in the first, day 0 infection, day 7, most people are going to show some symptoms. By week 2, they're either going to get really sick and have a COVID storm and die, or they're going to get better, most of them. So usually from the time you're infected to a few weeks later, that's when we'll see that kind of curve flatten. The virus is marinating in the community. Then 2 to 3 weeks later, it starts climbing. And as it spreads, it'll start doing this. So when people stopped going outside and really got scared, that's when you saw we flattened the curve and it went down. Then you hit Memorial Day and 4th of July. And then sure enough, a few weeks later, the numbers started going up again. So that was a second surge. Then it went down again because everyone freaked out and was like, oh no, there's a second surge, and then went down again. And then you have Labor Day and schools opening, and now people are, quote, COVID fatigued. And it's crazy because the numbers didn't come down to 0. So this isn't really the second wave. This is the third surge. But as we can tell, this is a second wave that everyone was talking about in the fall that we predicted for a long time. So that's why that curve has gone like that. And I think that's why you see these kind of peaks and valleys. And it's really all predicated on our behavior, which we can control.
Got it. So do you think the school reopenings did that, because we're talking about the cases started ticking up again, kind of early September, if the cases kind of lag behavior, will schools start to kind of reopen there, in August, middle of August, let's say late August? How big of an impact do you think that was on these new cases?
Well, I think we'll still see the impact of it. So
Okay.
it wasn't just colleges, but a lot of schools reopened in some sense, hybrid or full in person. A lot of the colleges were in person, and I think last I saw there maybe 70,000 college cases a few weeks ago was the last metric that I had. The New York Times actually is a great source because they post this all the time, the current numbers. But when you have those colleges opening, it's the same thing like prisons, military barracks. That's when flu and disease spread quickly because you're confined, a lot of people in kind of in close contact. And those are just breeding grounds for this virus and will make the numbers go up. So typically a few weeks after you have events like that and gatherings, then you're going to see the numbers go up. And, that's kind of a warning in that these people in colleges, when those numbers get too high or during the holidays, those kids are all going to go home.
Mm.
And if you have up to 40% of people who are asymptomatic, and the younger you are, the probably higher that number is, then those people are going home. And think of it like you're just exploding a grenade. And from that college, you're sending everyone out back to their homes. All the shrapnel's going all over the place, spreading the disease. And this was actually documented at a Florida spring break. It was in one of my Instagram posts. They actually there's a company called Tectonic that does GPS cell phone tracking. And they took a Fort Lauderdale spring break party. They tracked all the cell phones from that one night and saw where it spread. And they showed it on a map and a graphic. And sure enough, 3 weeks later, those are the next hotspots. And so, the same thing's going to happen. Just hopefully we can mitigate that.
Mm. So it seemed like they kind of backed into a kind of a form of contact tracing almost just with cell phone data.
It's very interesting because it's cell phone tracking.
Okay.
And it shows where people are going, but that is a proxy for contact tracing because you can see where people are going and where it's spreading, but you can't see the individuals and their contacts.
Right. Okay. It's just the geography, not the person to person.
I think there's a way that they can probably do that.
Right.
If they drill down enough, because cell phones track you to a few feet, right? So
right. Yeah, they can tell.
they can do that, but of course, they didn't make that data public, and I haven't seen it.
Right. So hand in hand with the recent uptick in cases, we've seen more states in the past few weeks impose more restrictions, from lockdowns to mask mandates. Going forward, what are the things that you believe that state and local governments can do or should do, kind of before we have a vaccine distributed, in order to stem this tide of new cases? Are these mask mandates enough? Are shutdowns appropriate? Enforced social distancing? What works and what doesn't, I guess, at this point from a government and enforcement standpoint?
Well, you know what, I think, as we all know, our government's response has not been a national coordinated guideline. A lot of local governments, state and local governments have been tasked with figuring it out on their own. And in a way that's so unfair to these governors and the people in those areas, because really they don't have the resources that the federal government does. You don't have access to the long-time career health officials and epidemiologists in our national agencies like the CDC, the National Institutes for Health, the National Institute for Infectious Disease, all those places, and they had to figure it out on their own. Having said that, one thing is some national guidelines that, of course, take into account the local differences, which will be many, right? So you have to kind of tweak those locally. But the most important thing and the biggest message that I can give to all the people listening is, we talk about vaccines, we talk about antibody treatment, we talk about Operation Warp Speed, we talk about PPE, we talk about all that stuff. It's important. But and talk about hospitalizations, all the treatments you can get, remdesivir, steroids, all that. But the most effective and simple thing that you can do is up to each individual, and that's you wear a mask, you wash your hands, stay away from people, and limit your contacts and gathering. And like I said in that zombie example, it has nowhere to go. It's the cheapest, most effective thing that every single person can do that doesn't require a federal mandate, but it just requires an understanding of how this thing spreads. And it's so simple and so cheap that everyone can do it. And you've heard the stats. If everyone masks up, 135,000 lives will be saved, right? 3,000 died on 9/11, and we went to war for 2 decades as a country, right? And we have 250K dead, and you got to wear a mask. I mean, it's not that hard.
Hmm. So let's talk about masks. You co-wrote an article with the inventor of the N95 mask. This article is in the Journal of Emergency Medicine.
Yes.
So I would say you not only know more than the average American about masks just by being a doctor, but you probably know more than even the typical doctor about masks because you have researched this. Um, why are masks effective, and why was there so much confusion about them early on, even maybe some of it coming from our own CDC?
Yeah. So, no, that's really unfortunate. Uh, the number one thing is, as the guidelines come out, they're based on the best information that those authorities have at that time, that moment in time. So Monday morning quarterbacking, everyone does it. But the thing is, at some point early on, I remember when at first it's like, okay, you know what, wear masks, it's droplet spread, but it's probably not aerosol spread
Hmm.
because there's some diseases like that. And like shingles, droplet spread, and you have measles, aerosol spread. And I'll tell you the difference in a second. But masks are decent enough for droplets that are big enough size for the mask to stop it. But there's some question about how it was most spread. And when they finally figured it out, then they came up with new guidelines. So that really explains it. There's a possibility that, there wasn't enough PPE around. We're trying to say PPE too. But there's a combination of factors. And unfortunately, what that did is because recommendations have changed over time, it has made sometimes people lose confidence in those recommendations, which I totally understand and get. But you got to remember that the only thing that trumps science is better science.
Hmm.
And as you learn more, if you're intellectually honest, you will change your mind if you get evidence that something's better. And that's just the way it goes. So right now we're at a point where we know that masks are effective. We know that it's droplet and aerosol spread. And we have to take that information and run with it.
So we talked about the N95 mask versus I don't have a mask with me, but just kind of those
Surgical mask.
cheap, yeah, surgical mask, right? Is something like the N95, or I think there's like another one, like a K, it's maybe a little bit lower, something like that. Is there a huge difference in the efficacy in mitigating COVID-19 between those, N95 masks and just a surgical mask?
There's this phrase I really like is that the more you know you don't know.
Right. Yeah, exactly.
And because, as you think, oh, N95 mask or surgical mask, oh, one's better than the other. Then when I started doing research about the N95 mask, I said, oh, there's an N95, there's an N99, there's an N100, there's a K95, there's, and all this other stuff. So as far as the N95 mask goes, the idea is this.